Vulnerable Populations team here at NASHP. And as Wendy said, today I'll be sharing highlights from our team's recently published report on state opportunities and approaches to supporting payment of family caregivers through Medicaid consumer-directed programs. Next slide, please. We've provided a link to the report here, and you can also visit nashp.org to read the report. As I said, I'll give a brief overview and highlights today from the report. Next slide, please. The COVID-19 pandemic has affected long-term services and support systems, particularly with regards to congregate care facilities. However, the demand for home and community-based services options as an alternative to institutional options was apparent before the advent of COVID. Medicaid.gov reports that in fiscal year 2018, the national average percentage of home and community-based services spending as a proportion of total long-term services and support spending was 56.1%. One way to approach support of home and community-based services is through Medicaid consumer direction, where enrollees choose, hire, and manage their care providers. While early pilot programs in the late 60s and early 1970s focused on people with disabilities, the consumer direction model and its core values of autonomy and dignity has since been applied to programs for older adults also. States have since expanded their consumer direction programs. Today, some key elements of self-directed Medicaid services, as noted on Medicaid.gov, include a person-centered planning process and assessment, developing a service plan, information about an individualized budget, and state information and assistance to support enrollees in their role as employers. States must also make financial management services available to support enrollees. Next slide, please. States are increasingly using consumer-directed models to allow flexibility for individuals to select and hire their own care providers. All 50 states and DC have at least one consumer-directed option. This support is likely to continue as states continue to address issues raised by COVID, seek opportunities to promote equity and access, and address growing caregiver workforce shortages related to high demand for services. Next slide, please. States have multiple decision points to consider when developing a Medicaid consumer direction program. There are a number of authorities through which states have the option to deliver consumer direction. This list above is a brief overview. A majority of states operate consumer-directed programs through the Medicaid 1915C Home and Community-Based Services Waiver Authority. Using 1915C waivers, states can modify eligibility requirements, target services to particular areas of the state, and/or limit or tailor services to certain populations, such as older adults or adults with physical disabilities at risk of institutionalization. This list is a high-level overview. Each authority has its own specific requirements and stipulations, which are highlighted in our report. States also have further considerations specific to the goals of their program to consider when shaping their program. Next slide, please. Other considerations to take into account include how care recipients, i.e. enrollees, manage their budgets, caregivers, and services. For example, employer authority permits recipients to directly recruit and manage their service providers. Employer authority is integral to the consumer direction model. Budget authority allows enrollees to manage their budgets and purchase other goods and services. States are also required to provide enrollees with supports in managing the consumer direction process, which can include training, information about their responsibilities as an employer, and access to financial management services. States must also consider what hiring and training requirements to set for those who can be hired in consumer direction. For example, Florida does not require licensing or certification to provide personal care, homemaker, or adult companion services, but does require licensure for attendant care. A key consideration within consumer direction is determining who can provide services. Within the 1915C waiver, for example, states have the option to allow relatives to provide waiver services and/or allow legally responsible individuals, such as spouses and parents of minor children, to provide personal care services under specific circumstances. When delivering personal care-related services, the legally responsible person must be providing care that is beyond the care normally expected. While it's outside of the scope of this current highlight to list all states that allow spouses or parents to provide personal care-related services in consumer direction, due to the COVID-19 pandemic, many states have submitted Appendix K amendments to 1915C waivers to CMS to temporarily allow certain services to be provided by family caregivers. These amendments are temporary, however, and revert at the end of the public health emergency. Next slide, please. In its report, NASHP conducted case studies of 3 states' approaches to consumer direction: Connecticut, Florida, and Virginia. Highlights include the following points listed here. Consumer direction can offer the opportunity to support culturally competent care. For example, through allowing individuals to hire caregivers who are fluent in the enrollee's preferred language. Family caregiving can also be considered a part of home and community-based services support and a potential approach to achieving rebalancing, i.e. shifting spending towards home and community-based services as opposed to institutional services. Additionally, outreach to promote programs and educate enrollees and their families about options through consumer direction is integral to achieving access. Due to the pandemic, states may have a heightened opportunity to raise awareness about consumer-directed options for personal care-related services within their home and community-based services. Additionally, data collection of caregiver information to better understand the caregiver population's needs, along with ensuring program integrity while maintaining care recipient and caregiver autonomy, is also a consideration. States use background checks, provider training and requirements, and care managers to support program integrity and quality care. Additionally, understanding the specific needs of consumer-directed enrollees and caregivers, such as user-friendly technology, and incorporating stakeholder engagement can also avoid challenges. Family caregivers employed through self-direction are considered employees and are subject to a range of state and federal regulations. Understanding how these regulations affect family caregivers is key to supporting program success. So these are brief highlights from our report. For more information, please check out our report at nashp.org. Thank you for your time, and now I will hand it over to Dawn Lambert at the State of Connecticut.
Thank you, and good afternoon from the state of Connecticut. I am Dawn Lambert. I co-lead the Community Options Group here within Division of Health Services. And I was asked to just tell you a little bit about the way that Connecticut supports family caregivers through the Medicaid program within the state. So next slide, please. What I wanted to do was to provide a general overview through the framework that you see on the slide, tell you a little bit about our history and a background. There's just one slide, so it's not intense, but just to give you an idea of what our journey has been that got us to where we are now, because Connecticut, I'm sure, as anybody's tried to implement a paid program for family caregivers, there are always some challenges associated with different schools of thought about which family caregivers should be paid, which should not. And we'll talk a little bit about those challenges. The second one is the way that it emerged in Connecticut really was through the role of rebalancing. And that's what Salom was just kind of pointing to, that sometimes this is a strategy and sometimes it becomes a little bit more under the magnifying glass through the lens of, are we equitably serving individuals in their choice of setting? Are they unnecessarily institutionalized? Do we have enough capacity in the community? So those discussions, and I'll tell you about our planning effort there, because that's what framed and launched community first choice and expansion to family caregivers. So connecting the dots from here's our history to here's the planning we did and who we engaged. Here's the new option that we rolled out, and then a little bit about our outcomes. Next slide, please. So our history, we did launch one of our aging and disability waiver, launched about the same time as our DD waivers, 1987, pretty much right after 1915C waivers were permissible. And at that time, there was no option for family caregivers in our state. We did have a small adult family kind of an option. It was not, there was not a lot of, it was not highly used at all. Was viewed, ultimately it was eliminated, but we did have a small option available, but literally no Medicaid option for hiring family caregivers. Now in 1996, we started self-direction, with the personal care attendant waiver, totally self-directed. And self-directed in Connecticut, with Connecticut means that the hiring, the firing, the managing is all done by the member, him or herself. And the fiscal intermediary is just there to actually support with the payroll processing. So 1996. From there, you can see that there wasn't a lot of activity until you see 2010, 2013, 2015. What ended up happening was around 2002, just after Olmstead and the Real Choice Systems Change Grants came out, for those of you who remember, in 2000, 2001, that's when things started to heat up in our state. There was a lot of visibility about, are we giving people a choice? How do we build the workforce? So the action that you see from 2010, we embedded self-direction for the first time. Gosh, that's only 10 years ago. Hard to believe it was only 10 years ago. Self-direction was permissible for our 65 and older population. And from there to 2013, we actually rolled out new adult family living, and 2015 community first choice, which expands the options for family caregivers. And we'll see over the next couple of minutes exactly how much that has expanded and addressed the workforce issues within our state. Next slide, please. All of this actually started though, back in 2013, the planning was 2012, and actually it started, as I mentioned, around 2002, but around 2011, we were actually asked by the governor for a formalized plan. And we called it, and we still do, the Strategic Rebalancing Plan, and that's done every single year. The path to the plan did take a couple of years. This was essential in our planning, and it still is essential today. And once again, is what launched the rest of the progressive activity around family caregivers. It is led by a steering committee, diverse steering committee. So a lot of stakeholder input, still meets monthly, started to meet monthly during Olmstead back in 2000, same group. Now some of them are older adults, participate as older adults, same group, still meets as a waiting list for membership in the group, and that they are a group of 23 people, co-chaired by the state ombudsman and the immediate past president of the ARC in the state of Connecticut. We also have evaluation, third-party assessment. That's important for our plan. It adds transparency to what we do, and data integrity is really important. It helps with that third-party voice that sometimes is really important with communicating whether we're successful or whether we're not. Next slide, please. Part of the plan was to actually work with Mercer and look at not just the entire state as a whole, but to analyze at a town level and do projections about what our initiatives, our planned initiative, the impact of those initiatives would be at a town level on nursing home census if we gave people a choice. So what we said to Mercer, assume that we give everybody a choice. We eliminate those policy barriers. We build out the workforce, assume that. And we're going to tell you what those assumptions are. Tell us what the impact will be at a town level. And tell us what workforce we have to build if in fact we're successful. And tell us that at a town level so that we can work with our local communities and support rebalancing by building capacity where it's necessary. Next slide, please. And so this slide that you see is a graph. We've done this many, many years now. At first, it was aspirational. You can see let's go all the way back to 2003. That dark blue line is our projection. The gray line, you see the bottom gray line, is where we started. It was the projection before we started the strategic rebalancing. The difference between the gray line and the dark blue line is the success rate. And so we put out these projections, we map things, and that future line is mapped by every single town. And it correlates directly to workforce projections needed to make sure that people have a choice to live in the community. Next slide, please. And so this is an example of the actual data of workforce. Now in 2000, this was as of 2018. At the end, I'll show you where we are right now. But you can see the impact. Once again, the plan came in 2012. We had, you can see personal care assistants, third line down, 2,477 personal care assistants. We had specific strategies to build out self-direction, to engage family caregivers through community first choice to help solve for what was projected. So we were projecting the entire time. And I remember the discussions in those days, and I will tell you, people looked at the numbers that they thought we had to build, and they were saying, you're never going to do this, Dawn. And I said, well, we have to do this. Let's just get the strategy. Well, by 2017, you can see how much we had increased literally overnight. We went from 2,477, third line down, to 14,600. That's an actual number for 2017. We're still projecting that we're behind a little bit in about 2,000. We'll need about 2,000 more by 2025. So we're building, constantly looking at this data. It's at a town level. This is a state roll up, but we have it by town level so we can share with our local partners. Next slide, please. So this is the actual high level strategy. And I mentioned town a couple of times. There's state policy that we have to work with. We've been working with the one stops. We've been building competencies. And we did this many, many years ago, but that was one of the first things we did to align what was going on in the one stops with a job seeker who might walk into the one stop looking for a job, fill out the inventory. We didn't have PCA as part of the inventory because we didn't have competencies. We needed to align, and we did that so that the one stops could be part of our building of capacity in a meaningful way. And I already mentioned town level partnerships. We share the information, and we go talk to any town who is willing to come to invite us and to help us in building the capacity needed at a town level. The town level strategy is very successful in Connecticut. It makes it meaningful for people. It's about their neighbors. It's about their community. Very effective for us in the state. Next slide, please. So based on all of that, we went from the strategic plan to a specific strategy, which was community first choice, to the meaningful integration of hiring family members in a way that we had never done before. I mentioned that personal care assistance was embedded back in 2010, but it was restricted. The only way we were going to pay a daughter to help take care of her mom was if the daughter quit her job. And she had to provide evidence. This is just 2010. She had to provide evidence to us that she quit. She couldn't just be at home trying to get a job, trying to help her mom and get paid for it. She literally had to quit. Community First Choice in 2015 changed that. We used to have there were the 3 lens in order to be a brother who would get paid to support your brother. There was a great deal of scrutiny around it, because of 2 things. One is from the budget perspective, and all of us who've been doing this for a long time, you can hear the discussions now, right? It's not just in Connecticut. From the budget office, everybody thought, well, that means everybody's going to want to get paid, and their family members, and so you're going to have the woodwork effect, right? We've all heard that. There's going to be an immediate budget explosion because these people are going to be new coming in. And my argument for that was, yes, but look how many workers we need. And these are workers who, and we've all heard this many, many times, workers who actually care, as well as for their family member, as well as actually providing care. Not to say that paid caregivers, that paid staff don't always care. I don't mean to say that at all, but there is nothing to me like a family member who wants to be there through that journey, being paid to do it if it's appropriate, and if they're if the member chooses it, not the daughter, but if the member chooses it, to have the family provide that service. To me, there can be nothing more dignifying than that. And I have a quick story about that. And the second one that we hear is these family members should be doing it anyway. Like, you're married, till death do we die, sickness and health, you should just do it. The family, you had the child with a disability, you're the mom, you just do. We've heard these discussions still exist within the minds of people, and people have different attitudes about who should get paid and where that line should be drawn. So we still have those discussions all the time. The quick story that I wanted to tell was about the cultural competency, and Salom mentioned this. The very first person who applied for Community First Choice, July 1st, the day it opened, there was a young man who wanted to apply for his dad. His dad didn't speak English. His dad did meet nursing home level of care, which of course is required, and spoke a dialect that I can't remember what the actual name of the dialect was, very, very rare. and also had advanced stage 4 cancer. And the problem was that the home health services, the medical services that we all know are part of entitlement of, Medicaid program, the home health aides that were coming to assist the father didn't speak the language. The son was calling, talking about the experience of how undignifying it was for his father as he went through the last few, as he was facing the ongoing diagnosis of cancer, how undignifying it was that he couldn't even speak or provide any direction to the people who are helping to take care of him. It was just so incredibly powerful to me. That particular gentleman, they did have a strong cultural network. They knew exactly who they were going to hire from that network of people who actually spoke the same language. The gentleman lived for 2 years. His son called a week after he died and asked to speak to his, and I will tell you, if you want to film something, you will never hear anything so powerful as a son thanking for the way that his father was able to die in a dignified way. It was absolutely amazing. And yes, some of the sons were paid caregivers for their dad, and gave up actually high-paying jobs in order to do it, which was not a requirement, but for them it was the honorable thing to do, and it maintained their own family stability while giving their father the dignity of being able to die with family and people who understood his dire life. Sorry, I spoke too long about that, but anyway, I could tell the story, a couple of other stories. I will not. Next slide, please. So we do not, I mentioned spouses, we do not permit spouses in the state. That was one line that we did, and we do not allow legally liable. Maybe by next year, if we do this again, Wendy, maybe by then we will permit, but right now we do not permit spouses, although it did come up quite a few times during COVID-19, but it's not permissive under community first choice, nor is it permissive to be a conservator. I will say one key fundamental important aspect of a policy that we changed aligned with this is the Medical Practice Act in terms of nurse delegation. So personal care assistants are carved out of the Medical Practice Act of the state, which means that if there is a skill task that is required, and if the member is alert, oriented, competent, or if the employer, who might be a designated employer, is that personal care attendant may perform medical tests under the direction of the participant or the employer. There is no required nurse supervision within the state of Connecticut for personal care attendants to be able to perform medical tests if in fact it's appropriate and if that's what the member wants. This is highly beneficial, I will tell you, highly beneficial to children with who have complex who need complex care, because it does provide parents with the oversight to hire people, and parents would otherwise be doing it, but to teach somebody else who's a trusted, reliable person to provide some of the medical care has worked out very, very well for the families. So next slide, please. The other initiative that we have right now that's part of the Medicaid program is a caregiver training initiative. It's aligned with Community First Choice. We did a number of focus groups, and we learned that and you all probably hear this all the time too, that caregivers really need some assistance. They're happy to do it, but they really need some support, especially with medication administration, especially with behaviors generally related to dementia. A lot of questions come up, and so they're happy, but in order to really avoid burnout, we really need to be able to support those caregivers, both paid and unpaid, so that the family remains intact and that the person who's receiving services continues to have a choice, but the whole family is okay, not just the person that we serve. Next slide, please. So these are our results right now. I showed a little bit earlier that 2018, this was as of a week ago, and you will see the explosion in the workforce in the state. These are actually, you'll see our new projection 2028, 39,000 PCAs, we believe. If I showed the home health, you would see a similar decrease for home health aides. You see the medical model decreasing in demand, while the personal care self-directed model is growing. A portion of that is definitely family caregivers. It's not all family caregivers, but I would say it's about 20% family caregivers, where families are hiring families. But you can just see that's just 6 years, from 2013 to 2019. That's over 20,000 new workers in the system, new personal care attendants. And that's the impact of hiring family caregivers and offering the community first choice option. If I showed you the rebalancing numbers, you would also see exponential shift towards community. But we have to have the workforce if we're going to do that. And so this has been one strategy that's been really effective for the state of Connecticut. Keeps families intact, is dignifying for the family itself, cultural competency. There's a lot of objections that we have to overcome. So if you haven't done this yet, and I'm sure Nicole and Jason are going to tell you there are objections that you have to learn how to overcome, but it is absolutely worth it in the end to see family taking care of family and have that stability and peace of mind that comes from that, and offering choice, most importantly. So next slide, please. I think with that, I'm going to turn it over to Jason and Nicole, the state of Virginia, and look forward to hearing about the great work that you guys are doing. Thank you.
All right, excellent. Thank you, Dawn. Good afternoon, everyone. As Dawn noted, my name is Jason Rachel, and I'm the director of the Division of Integrated Care here in Virginia's Medicaid. And I'm joined by my colleague, Nicole Martin, the director of the Office of Community Living. I'll kick things off for us, and then turn it over to Nicole to share some of the details around Virginia's efforts in paying family caregivers through consumer direction. But before we begin, I'll start with just a quick landscape of Virginia Medicaid. Next slide, please. So we are a Medicaid managed care state, and serving almost 92% of our 1.8 million covered by the Virginia Medicaid program in Virginia through a managed care product. When we have we have our Medallion 4, that is what we consider our traditional Medicaid, serving women and children, caretaker adults, and the newly eligible adults through Medicaid expansion. And those services include child well visits, acute care, pharmacy, birth and vaccinations, and behavioral health services, as well as community mental health rehabilitative services. And it does exclude long-term services and supports. And that's where the Commonwealth Coordinated Care Plus program comes into play, serving nearly 275,000 individuals. Those would be our aged, blind, and disabled, those that are medically complex through our Medicaid expansion program, as well as our duals are, again, all covered with our CCC Plus program. Just as with Medallion, it covers the full continuum of services, as well as our long-term service supports home and community-based services, a nursing facility, and hospice services. Next slide, please. So as I noted, Nicole will talk through the payment mechanism for paying family caregivers in Virginia. But I'd like to just share a couple of moments with you, some of our efforts around supporting family caregivers as a whole, and DMAS and the Commonwealth certainly understand the value that family caregivers bring to the healthcare delivery system. And we had the opportunity to work with the Center for Healthcare Strategies in a program known as Helping States Support Families Caring for Aging America. And it was a real opportunity for us to collaborate not only with national experts, but other states with regards to other opportunities in identifying as well as supporting family caregivers. We joined forces with our sister state agency, the Department of Aging and Rehabilitative Services. And the overall goal of that project was to develop tools to engage and support family caregivers, essentially to strengthen home and community-based living. So, we again wanted to recognize the role that family caregivers played in home and community services, and wanted to see how we could better support them in that critical role. Next slide, please. So we knew we needed to hear from others. So we convened a stakeholder work group made up of staff within our agency, the Center for Healthcare Strategies, as well as DARS, the Department of Aging and Rehabilitation Services, the Alzheimer's Association, AERP, and community agencies and community CBOs, community-based organizations like AAAs. And this group actually, in a very short amount of time, got quite a lot accomplished. Next slide, please. We we knew it was important to see what was already there. And for those in other states, I hope your experience, if you ever conduct an environmental scan of family caregiving supports, discover what we discovered, which is, wow, there's a lot out there, but it's fragmented and very kind of locally based. But there was a good amount of activity around supporting caregivers. We also knew that we needed to leverage our managed care model, and so we worked with the health plans. And despite all the significant oversight that we provide to the managed care organizations, we don't always know what they're always up to, and some of that is good stuff, I will say. And one of those was they actually had a good amount of activity around supporting family caregivers themselves. So we brought them in. And we also recognized that the model of care that we engage in with the health plans to support our members and quite frankly support family caregivers, there was an opportunity to leverage the model and leverage those touch points that already exist with in conducting health risk assessments, in developing plans of care that we could link into and engage family caregivers. And when I mean engage family caregivers, I really kind of both identify and support, and really kind of want to see where they are with regards to their stress levels. That we all know that for those that have been a family caregiver, it's not some linear, smooth a path, right? It's with regards to stress levels, it's up and down, it's peaks and valleys, and there needs to be a good relationship for and support available to caregivers, because sometimes things go well and sometimes they don't. And when they don't, we want to be there to be able to support them. That's what this group came up with, and that's why that's where we wanted to focus our efforts in both identifying who they are, have the resources available, and then have a mechanism so that they could get the support when they needed the support. And another way that what the group did was we trained 300 of our care coordinators on resources for caregivers. And this was, again, utilizing the natural touch points that managed care brought to rendering services for Virginia Medicaid recipients. It was, hey, when a care coordinator is in the home and they are working with the member, and the family caregiver notes a particular stress, as Dawn said about training, right? That there could be, they'd have the knowledge to refer them to a resource that could help them overcome that particular challenge. And so, this would be an ongoing effort, but we were very encouraged by the engagement and the level of interest by our health plans and the care coordinators, again, who are interacting on a daily basis with Virginia Medicaid recipients. And then we also had the opportunity to join a Virginia Caregiver Coalition. Again, one of those things that we didn't know was even happening. And wait a minute, there's a whole statewide coalition on caregiving. DMAS wants to be at the table. And so we invited them to our table and they invited us to theirs. And so, again, we see a lot of opportunity here moving forward with more creative ways that Medicaid can support caregivers and as they support their loved ones and our members. Next slide, please. So just like everywhere and everyone, COVID-19 threw a kink in our plan as we were moving forward. We were looking to create that survey and use the natural touch points and get it both identify caregivers as well as see where they are stress-wise and what resources we could make available to them. And we had to kind of put all that on hold, recognizing that COVID-19 really, well, it was tough on everybody, certainly, but wow, it was really tough on family caregivers as the lockdowns and everybody was home, and so we pivoted quickly to say we need to provide kind of information on supports that are available right now. And so we partnered with Virginia Navigator, which is a guide here in Virginia to local resources to support those with disabilities and those who are aging. And we did an email campaign. I think they call it a drip campaign. I think that's what my techie people tell me, or my marketing people, where you just kind of just drop a little bit in and then you wait and then you give a little bit more. And so we've done topics on food assistance, housing assistance, and self-care. And I don't have the click rate. I meant to get that before the presentation, but I was told it was a great click rate or open rate. I think that's what they tell us is, and so, we were very encouraged by that. And again, before turning over to my colleague, I'll just say that we certainly recognize through this opportunity with CHCS that when we're able to better support family caregivers, they're better able to support our members. And, that's kind of why we're all here. So thank you very much for the opportunity to speak with this afternoon. And it's a delight and to turn over to my colleague, Nicole Martin, to talk through our family paid caregiver initiative. Nicole, all yours.
Good afternoon, everyone. I'm going to talk to you a bit about our consumer-directed program, talk to you also about our family caregiving flexibilities and some of the things that we've done during COVID and beyond. So first, I'll just give you an overview of consumer direction in Virginia. We've been doing consumer direction. I believe it started in the late 90s and really picked up in the early 2000s. We have experienced exponential growth since the early days of consumer direction. And right now there are about 23,000 people who are choosing to direct their own services or to use consumer direction. Those 23,000 people employ about 30,000 attendants. And the services that they're able to provide are personal care, respite, and companion services. So we are very proud of our consumer-directed program. We're very happy that this is able to, people are able to access these supports in the way that they want to access them. We utilize the employer authority, which means that the member or the person that they choose to represent them becomes the employer. They have all of the hiring decisions, all the authority to manage that employee, and sometimes they even have to terminate those employees. So they are the employer. The state is not a joint employer or a third-party employer. It is all managed by the member or their representative. Now, the one thing that the member or their representative they don't manage is the budget. We don't have budget authority in Virginia, but the rates are set by the Virginia General Assembly that the member or the attendant gets paid. So we don't have the authority for the employer to, designate how much money is being paid to the attendant. We do have a fiscal employer agent. Actually, there's multiple fiscal employer agents in Virginia now because we have managed care. So MCOs, they contract with fiscal employer agents, as well as for those that very small fee-for-service population. They also have the state contracts with a fiscal employer agent. Services facilitators are providers that support the members in accessing that consumer direction. Because it's one thing to say, hey, you can direct your services, but you do need a middleman. How do I direct my services? So we have this provider, they're called services facilitators. They help the member develop a plan of care. They submit that to the authorizing entity, whether that's DMAS or whether that's an MCO. They also help the member get connected with the fiscal employer agent and help them get set up with their payroll. So that is in place for the members as well. Next slide, please. So family caregiving in Virginia, family caregivers are permitted to be reimbursed for services. That's true for agency direction and consumer direction. We have there is a caveat. The only generally legally responsible individuals are not permitted to provide services to be reimbursed. And that's, when I say that, I mean parents of minor children and spouses. But hold on to that thought because we're going to talk about that a little more. Family caregivers must meet the same requirements as all of the other attendants. They must pass criminal background checks. So the requirements aren't great. There's no specific training requirement that they have to go through. It's minimal requirements. So it really is who the member wants to provide that care for them. We don't really keep track of how many family caregivers there are. There's no official tracking mechanism out there because when we set this program up, we said, you can be a family member and provide care. So we didn't track it. We do believe, however, there's about 40% of the attendants in consumer direction are some sort of family member. And again, that is just what we believe. We don't have any hard data to support that number. But part of the reason we got to that number is we do track how many live-in caregivers we have. Because in this program, you could also be a live-in caregiver and be reimbursed. And a lot of the times from our experience, those living caregivers are actually family members. So we have about 40% of our population that are living caregivers, which leads us to believe that it's about 40% of family caregivers. And they are self-disclosing that they're family members, or that they're living caregivers. So living caregivers are treated basically the same as other attendants, but there are a few caveats. One, living caregivers are exempt from our electronic visit verification requirement. So they do not have to clock in and clock out. So they can still just put their time in through our web portals. And so it's not in real time. Live-in caregivers can work more than 40 hours in a week. So there are no limits to how many hours a week a live-in caregiver can work. But the flip side of that is live-in caregivers do not earn overtime pay. And just recently we started providing overtime pay. Back in January, we are able to pay up to 8 hours of overtime per week for people who are not live-ins. And then the other thing about live-in caregivers, there must be documentation while no one else is available to provide that service. We're not asking for huge documentation. Sometimes it's a language barrier. Sometimes the member, there's behavioral situations where it just makes more sense for someone who lives with that person or that family member to provide care. So it's not something that we are, we just want to see it in documentation that there's a reason why no one else is available. Next slide, please. All right. So remember, I told you to put a pin in that legally responsible, not allowing legally responsible individuals to be reimbursed. When COVID hit, there was big concerns about making sure that people were able to access the care that they needed, especially those folks who receive personal care services. So we're talking about people who are meeting the nursing facility level of care, or they have a developmental disability. We wanted to make sure that the access to care was there for them. So through an Appendix K, we did temporarily expand the qualifications to be a caregiver, and we did allow parents of minor children and spouses to provide care, personal care services to members. We did keep track of that because we knew it was temporary, so we would have to turn it off at some point. And about 1,600 people took part in that. They were employed to provide this support. We are scheduled to phase that out August 1st of this year, and we'll see how that goes. We do know that people very much liked being able to provide that support for their children or their spouses. We've gotten a few inquiries about that. So I would not be surprised if this is something that is introduced in some legislative initiative next year to bring this back and make it permanent. But as it stands for now, we are scheduled to phase that out in August. Next slide. We also, during COVID, wanted to make sure that our consumer-directed population had access to other things. We wanted to make sure they also had access to PPE or personal protective equipment. We at DMAS distributed over 120,000 cloth masks by mail to our consumer-directed members. And that picture is actually our staff who went in and packed all of those masks and sent them out to our membership. We had those masks on hand through our emergency operations center for Virginia. So we quickly were able to get those out. But the real program we really wanted to do was to allow employers of record and consumer direction to be able to order PPE and receive it as they need it. I don't know if you all, I'm sure you all remember, there was a shortage of PPE at one point. So this was a bit of a feat, actually. We were glad we were able to actually get those masks out as a first run, because it took a while to get the mask and the gloves and the sanitizer on board. But we were able to get that program going through the Support of CARES Act funding. We did distribute over 18 million gloves, 5.5 million masks, and hand sanitizers to employers of record in the consumer directed program. And we know that family members, family caregivers benefited from that particular initiative. And it's one of the things that we're really proud of, that we were able to actually do for the members. Next slide. We have some other changes. They're not necessarily COVID related, but our consumer directed program continues to grow. It continues to expand, and we continue to enhance it. Starting July 1, attendants will be able to work up to 16 hours of overtime per week. So we went from allowing 8 hours back in January. Now we're going to extend it to 16 hours per week. So that's providing more access to care to our members in the community. We've got a couple rate increases scheduled. May 1st, actually, there was the first rate increase. It went to we increased the rates by 6.4%. There'll be another rate increase in January of 12.5%. This is all, Virginia is getting a minimum wage increase, so we are staying on track with that, and we are above minimum wage. And both of these raises will put us above the minimum wage for Virginia. Also, we are tasked with providing a paid sick leave program this fiscal year. Attendants will be able to earn up to 40 hours of paid sick leave every year. They will accrue that sick leave at a rate of 1 hour for every 30 hours that they work. And that's for people who work an average of 20 hours a week or more. So we're very excited about that initiative. And then we're also developing a standardized attendant orientation training. Now, this training isn't designed to teach them how to be an attendant because that's the employer's responsibility. So we are very careful that we don't want to overstep our authority because we are not the employers. But we do want to arm the employers with some tools that they can train their members with. So we are putting together attendant training orientation that talks about, it'll just have an overview of consumer-directed services, explain roles and responsibilities, not only of the attendant, but of all the pieces, all the people that are involved in entities. We'll make sure they understand fraud, waste, and abuse, and their requirements as a mandated reporter for abuse, neglect, and exploitation. Next slide. So that is what we put together today. We really are honored and thank you for inviting us to share a bit about our program today. And with that, I'll turn it back over to Wendy.
Yes, thank you. Thank you all so very much. So we received quite a few questions about eligibility to the consumer direction programs, because I know you all mentioned a number of different, nursing home level of care, children, people with IDDs, seniors. So could both of you both states kind of give us a little bit more information about who would be eligible for these type of programs?
So I can go first, I guess. In Connecticut, anyone who is at least at nursing home level of care or higher and is covered under any Medicaid benefit group. So that does include children in the state of Connecticut. A lot of times it's more the children who are on the Kitty Beckett waiver. But it could be a child who's covered under a family coverage group as well. And as long as they have the benefit and they meet the level of care, they have access. It does include coverage for the expansion group. So that the single adults Connecticut's an expansion group state. And so that's a relatively large group in the state of Connecticut as well. So bottom line, if you have Medicaid and you need the service, you have access to the service in the state.
In Virginia, people who are using consumer-directed services are generally enrolled in one of our 1915C waivers. So that would be our waiver for people who are older or have physical disabilities, or one of our developmental disabilities waivers.
And then is the training for family caregivers, is that mandatory or is it optional?
The training, I think if you're referring to the training I was speaking of in Virginia, it is going to be optional.
And then Dawn, is it optional also in Connecticut?
Yeah, Connecticut. So we've taken it sounds like, Nicole, a similar position. And I know this is discussed broadly of should there be absolute competencies and should there be mandatory training? And that's a big debate right now. We in the state of Connecticut are firmly have the position that it is the employer. And Nicole, I heard you, I made me very happy to hear you saying this. We believe that the employer knows the needs of the employer best, and that it should be the employer who has the opportunity to do the training. Not to say that we shouldn't provide resources because they're available, but that there should not be mandatory training that supersedes the employer's right to choose and to have autonomy in that decision making.
And then one of the major kind of barriers to this program, and I've heard it by other state officials, is the worry about the potential for fraud in this program. Have you experienced that? Is that a concern? How is your state dealing with that in this program? Dawn, you want to go first?
I was going to pick Nicole.
Oh, okay. Are we doing Nicole?
That's okay. I'll do the fraud question. You're right, Wendy. State of Connecticut, 2015, community first choice. We've had self-direction, as I mentioned, for a long time, but community first choice is an entitlement. It's a little bit different because it was literally, for the first time, the state had access to community care or access to institutional care as entitlements. And the program grew exponentially really, really quickly. We have been audited 3 times. 2 times by the federal government, specific to the question of, is there integrity and where are the checks and balances? We've done, and we did very well on both those. I'm here to say right now, going through the state performance audit. So that question is out there. And I know that we're all experiencing that. It in part, EVB is in part a legacy of some of the discussion about personal care attendants. And so we're all kind of experiencing that, but it's absolutely a question. Is there fraud? You know, I'll tell you there absolutely is fraud in the self-directed program. And I'll tell you there's fraud in every other program out there. And it's not a magic bullet that eliminates fraud. But if you say to me, is there more fraud in self-direction, especially when you define it in terms of dollars, I will tell you absolute myth. And I will give you example after example of where indictments have been an institutional side, where the dollars are millions and millions and millions and millions of dollars. There's literally no comparison. So I understand it, I get it, but as you can hear, I have a lot to say about it. I believe, and we have individual budget authority, I will tell you that just because somebody has a disability does not mean that they can't make as great a choice as a colleague who sits next to me at the Department of Social Services. It's an unfair assumption that the people that we serve are not capable of decision-making and making those right choices and managing their own lives. And so I feel pretty strongly about it.
Yeah, and I would just echo your statements, Dawn. Oftentimes that is a real big concern of folks, saying that that consumer direction is rampant with fraud. And we just have not found that. In fact, we have initiatives that when we do our audits, our normal audits, we look at consumer direction, and we have never found more fraud in consumer direction than we have in agency. It's just not there. Now, like you said, are there some cases where people will abuse the system? Absolutely. But it is not rampant. That's just not our experience. And we're always looking for ways to make sure that there are ways we can tighten it up. I mean, the service facilitators are there to help button it up, as well as with the managed care coming on board, everyone having a care coordinator, also looking, and even with our fiscal employer agents, there are a lot of eyes on this. And so, there are things that we can do to help make sure that fraud doesn't happen, but it is not a huge problem.
Great. Well, gosh, with that, I want to thank our speakers today. You all were fantastic. And I also want to thank the John A. Hartford Foundation for their very generous support, and in particular, our project officers who are fantastic, Ronnie Snyder and Scott Bain. Thank you all. Thank you to our participants for joining us today. And if you can, do us a favor, if you can stay on with us just a bit and fill out a survey at the end of this webinar, we would really appreciate your feedback. And with that, thank you, everyone. Have a good day.